So the next question for each of you is, Dr. Esselstyn, do you recommend statins for people? Dr. Campbell, a lot of speakers today recommend whole food plant-based diets, and they all sound very convincing, but there's also a whole bunch of keto, low-carb people who also have credentials, they're medical doctors, they're authors. What do the long-term studies say? When you look at all the unbiased, large, long-term nutrition studies, do they show that whole food plant-based eaters have significantly less disease and live longer than people eating diets that include animal products? Dr. Montgomery, what have been the results over the last 15 years among the patients that you treated with the standard medical care for cardiovascular disease versus the ones that you treated with diet and lifestyle? What has been the difference in results? And Dr. Lee, two questions for you. How does alcohol affect our health? And what should you do if you do get COVID-19? What should you do if you got COVID 9 months ago, but the symptoms still haven't gone away, and you're one of the people they call that have long COVID? If you could each answer that, and I guess we could do it in order. We could do Dr. Esselstyn, then Dr. Campbell, then Dr. Montgomery, and then Dr. Lee.
Yeah, fair enough. Well, the statins were introduced in 1986, roughly. And what are we now? We're over 30 years into statins. And when the statins were invented, the leading cause of death of women and men in Western United States was cardiovascular disease. And apparently that figure hasn't changed very much. So they really haven't quite been a revolutionary drug. And I was just recently looking at a study several days ago that was in the older patients where you had to treat 100 patients with statins for 2.5 years to spare somebody from having a single event. And there are some serious side effects with statins. And that is they can have severe muscle cramps. You can get liver injury. It can cause diabetes. And it can give brain fog. Now, what we have is I run every month. I have an intensive counseling seminar, usually for no more than 18 or 20 patients. And this is all done virtually. But the patients seem to come from throughout Canada, throughout the United States, and some from overseas. And it's a very intensive single day, 5.5 to 6 hour study where these patients are going to learn all about how they have created their disease and precisely how we want to empower them as the locus of control to halt and to reverse their disease. And we kind of looked up what our batting average was with that group. And I should mention also, my secretary will give me a list of the patients who are attending the seminar, usually 10 days beforehand, so that I have an opportunity to personally call each of them myself so I can get my arms around their story. And at the same time, it will provide them with an opportunity to ask questions of me so that coming to the seminar, we have a strong platform from which we can all move forward. And what I have come to find, of course, all these patients, they're self-referred, and they all seem to have a cardiologist and very often a primary care physician. And we have any number of them, before they ever come to our seminar, they have learned that they cannot take a statin because of the side effects. And what we found, and we looked this up, I guess the last time was in July of 2014, the Journal of Family Practice. We looked up some 200 patients, 2 of whom lost to follow-up, the 198 patients, of whom 177 were compliant with our approach. And it was really quite exciting to see that even those who didn't take a statin, as long as they were following our program, did absolutely wonderfully. As a matter of fact, there are several striking examples in my book, Prevent and Reverse Heart Disease, of some of our most profound reversals on an angiogram and also on persons who didn't take statins, some of the most profound reversals. So I I really try to work it out so that I don't ever get in a wrestling match with any of the physicians who are caring for these patients, because I would say that all of them who come to see us with heart disease are already on a statin, unless, as I've described, they cannot take it. And when they're taking this medication, or whether they're not taking it, people now, I think, have the confidence of what can happen with whole food plant-based nutrition. And here's how it works. When they leave our seminar, they go back, and let's say 2 or 3 months later, their doctor does another lipid profile for them. And he'll say, my goodness, you really have, your hypertension has come down. You've lost 20 pounds. We're going to have to reduce or get rid of your hypertensive medications. My gracious, your diabetes has gone away. I'm glad you noticed that and reduced your diabetic medication. And it looks like we're going to have to really stop your cholesterol medication because your cholesterol is really gone out of sight here. And that way, over the last 34 years, I have yet to receive a single phone call or email from a physician saying, Dr. Esselstyn, how dare you teach my patient the healthiest diet on the planet? So I think where it comes down to this, almost all the studies on statins, when you think about it, all the studies on statins were done with what? With the control group was eating the Western diet. And I like to look at what's happened in ischemia for a moment. As you know, ischemia had 5,000 patients in it. And of those 5,000 patients, there were 3 groups: optimal medical therapy with bypass surgery, optimal medical therapy with stents, and then optimal medical therapy. And of course, at the end of 5 years, there didn't seem to be any difference in major events. But my disappointment with that study, although it may have been a little bit too challenging, I didn't think for a minute that what they called optimal medical therapy was optimal medical therapy. How many of those patients do you think for 5 years wasn't having a drop of oil? How many of those 5,000 patients over 5 years were eating 6 green leafy vegetables daily? Yeah, I mean, it's interesting. So anyway, the bottom line is that you're going to do okay if you can't take statins. And how many statin drugs do they take in the Papua Highlands, rural China, Central Africa, where there isn't any heart disease? Yeah, I think it's a bit of a crutch. If patients are on it, I don't take them off it. If they're not taking it, I don't start it.
Thank you.
So I'm next, I think, Steve.
Okay, yes.
Yeah. So the question concerning, the long-term effects of the so-called keto diet, I got to go back in a little bit of history that most people know. That has obviously started with Robert Atkins back in the 1973s, as we generally know, who was actually at the time opposed to the emerging evidence coming up at that time, about a plant-based diet, used in different terms. But in any case, he didn't particularly care for that. He did receive some funding for that point of view, I have to say. But in any case, he was interested in cutting down on carbs. He said it wasn't fat. It really wasn't fat that was leading to better health. It was the high carbs. So he devised this diet, low carb diet, very low, as many of you may know. And of course, when people go on that kind of diet, especially when they got weight to lose, they lose weight. Body fat is burned, keto bodies are formed, or ketones, if you will, are formed, and that kind of feeds into the cycle of depressing appetite. So appetite kind of stays down for a bit. And so, and also, I think a few studies sort of showed some decrease in serum cholesterol levels. That impressed people. That impressed some folks, at least, who wanted to believe it to begin with. So the keto effect became a little bit attractive in the short run. I think we have tended to see that over time. But the point is that most of the studies that I'm familiar with, not really very good studies, but nonetheless, people go off that diet within 6 months. It doesn't stay around. And so, yeah, they lose some weight. And as I say, everybody wants to lose some weight who's got weight to lose. So that's it. But the key thing about a keto diet, low carb, obviously is high in fat, high in protein, and by protein, that usually means animal-based food, animal protein. So the keto diet is exactly the opposite of what we're talking about here. And that leads to the question then concern, how long does this go on kind of thing, this whole food plant-based diet? The data that I like to think about when trying to think about that question are mortality data over a lifetime. Because obviously, we're talking about end of life experience or later ages. And very clearly, the diet that is high in animal protein and high in fat,
Don't lose it. It's okay.
they in fact are higher in the various systemic diseases. They die earlier. So it's exactly the opposite of what the early effects of keto might indicate for some folks. It simply is the opposite. So the keto diet has no merit, no basis in, for sustained health, and should be avoided. I don't know how to quite answer that question about for those who want to lose some quick weight. I think there's some other ways of doing that without going down this keto track. But yeah, I think the keto diet, from my point of view, at least from the data I'm familiar with, is pretty well dismissed.
Thank you.
I think I'm next up. So the question is, in my experience over the past 15 years, standard medical treatment versus dietary and lifestyle treatment, which is done better. Clearly, our experience has shown a lifestyle intervention to be superior now. Most of our formalized data shows in the acute setting. Because of the nature of my practice, I'm treating patients who are acutely ill. And so a lot of our data shows the acute intervention of lifestyle versus medication. And so a lot of our published data, as well as our track data, covers a period of months. So we don't have longitudinal data, say, over 15 years. But what I can say anecdotally in my clinical practice, the patients that I've managed with the standard regimen who are not willing to undergo the lifestyle intervention, they do poorly compared to patients who over 15 years follow the lifestyle regimen. Now, when I say follow the lifestyle regimen, we have a pretty aggressive, precise, some people call it stringent, extreme lifestyle intervention. We put them on detox regimen. We put them on a regimen where they, can eat cooked foods for a certain period of time. They do intermittent cleanses and detoxes if they have a chronic illnesses periodically throughout the year. And we follow them regularly. And individuals who follow this regimen fairly closely do very well, because we found that we have a reduction in the number of pharmacological agents that they require. We also have a reduction in the amount of hospitalization, a reduction in the number of procedures, and even our patients who, quote unquote, fall off the wagon. So we follow them chronically and they fall off the wagon from time to time. They get off and they consume food. Today, I saw a patient who was in one of our nutritional boot camp classes many years ago. And, she knows how to detox and the like. And during the coronavirus, she was in the house and, she gained weight and wasn't feeling well. And she knew what to do. She went and did a nutritional detox and cleanse, and she lost weight and improved. So they gain a level of understanding because what we provide our patients early on through our aggressive nutritional cleanses is we provide them with an experiential knowledge. So once someone gains an experiential knowledge, it's something that you hold close to the heart. There's a maybe 6th or 7th sense of understanding for the benefit of what that is. So it goes beyond just the intellect, beyond reading some articles, but you gain personal experience and it has an extra dimension to your knowledge. And so a patient who obtained that, they carry that for a long time. And so what we have seen over longer than 15 years, about 2 decades, is they have reduced medication, reduced hospitalization. And these are patients with, near end stage heart failure who, have had bypass surgery in the past. One of our patients in his 70s, and, he's got 2 kids that are 2 years old now, as a younger wife. They have a much greater quality of life and a much, greater longevity because they're following this regimen, as opposed to individuals who just simply turn this approach down. We have to add medication after medication, because what we're doing is we're only treating symptoms and we're not really addressing the underlying biochemistry and physiological problems that occur. And the origin of those problems really start at adverse lifestyle components problems, such as the bad food they eat, lack of fresh air, sunshine, and the like. So it's clearly hands down in our experience, and we published this data heads on with reduction of medication, with a defined plant-based diet, and improvement in patients' clinical condition in the short run. And our clinical experience anecdotally shows the same to be present in the long run.
Thank you. Dr. Lee?
Can you repeat the question? I think it was about COVID.
Yeah, two questions. How does alcohol affect our health? And what should you do if you have COVID? And what should you do if you had COVID 9 months ago and you still have the symptoms and you're considered a long COVID or long hauler?
All right. Well, you know, the question about alcohol is a broad one, but kind of an obvious one. I mean, alcohol. There are some very decent studies that show that red wine and certain types of alcohol consumption regularly can actually be beneficial. But actually, most of those studies have also involved people that actually are eating better generally to begin with. So I would say, and the benefits are not due to the alcohol; they're actually due to the bioactives that are extracted by the alcohol in the beverage itself. You know, I mean, alcohol over time and at high concentrations has all kinds of devastating effects on our body. Everything from damaging our liver to stunning our bone marrow, including our stem cells, to impairing our brains, kind of pickling our neurons, to wreaking havoc in our microbiome. I mean, I think there's a litany of things that excessive alcohol actually can do. So, you know, I think, and that's been pretty well established. So I would say, you know, as a general rule, you know, most people, you know, most doctors are actually advising their patients to say it's fine to have a little alcohol. I mean, but not to actually have regular high consumption of alcohol. There's nobody that would actually agree that that's actually a good thing for you. With regard to COVID, you know, this is still very much of a virus and a disease that we're getting our arms around, and we're still trying to understand it. I would say it's not really clear exactly what you do, because most people who develop COVID actually will recover, at least in the immediate sense of the word. You know, well over 99% of people will actually recover. They may not feel that well, but they'll actually recover. And even people who are vaccinated can be infected and can be under the weather, so to speak. But most of them will actually not die. What is sort of more troubling is that some people, initially we thought it was people who actually had comorbidities, elderly, diabetic, obese. And we also then realized that some of the more vulnerable populations included brown and black populations, and that may not be due to the color of their skin. It may be due to other socioeconomic aspects as well, seem to be getting sicker. And but now we actually know that it's much more than that, because we can't really predict who's going to wind up getting really sick from COVID. So younger people now are starting to get sicker. I was just reading earlier today that the largest, highest group of people getting COVID are a population in the 20s and 30s. And most of them don't get that sick, but they do get sick. And we also just began having reports that children who get COVID are now also reporting getting long COVID, or the post-acute sequelae of COVID as well. And so this is a disease that, you know, almost at every turn is giving the medical community a surprise that we haven't quite seen before. So we're really working hard to actually understand. So I guess what I would say is this: you should get vaccinated if you can, and if you don't have a reason not to be vaccinated, because that's the safest way to get towards the light at the end of the tunnel, not only for an individual, but for society as a whole. Obviously, that's a free choice in this country, but we do know that vaccines for smallpox and measles and polio generally are how we actually move forward to improve our public health. We also know that the vaccines seem to have a very high protective ability, so that, you can step over the line and largely be protected from dying, which to me is a win. If you do get infected, I would say, what we know is that you're probably going to recover at home. So you kind of take it easy, and try to just recover. If you start feeling really crappy and feeling sick, it's better to get to the hospital. And we do know that there are monoclonal antibodies that have been approved for emergency use by the FDA that can actually make the severity of illness much less. And that's a treatment that, that people are beginning to talk about. And also, if you actually wind up being admitted to the hospital, let the doctors who are gaining experience now make the decisions of how to prevent you from requiring the ventilator. We're way ahead in this country, in America now, from where we were a year ago, where we weren't really sure what to do. I think that the save rate for people with COVID is actually quite good in the hospital, although, and I think here's another sort of hidden thing that people don't realize, is that high death rates like we're seeing in India, but also in Brazil and other parts of the country, and we saw in New York and other places, high death rates occur actually when our hospitals and our health systems are overwhelmed. And we've got too many people in a hospital that we can't take care of, and they're all acutely ill from different parts of COVID. That's really what was really starting to overwhelm us and leading to high deaths. So as far as long COVID, again, we don't really understand everything about this. The three things we are beginning to see in long COVID is microvascular damage to those endothelial cells that we've been talking about. We're starting to see that they have an autoimmune and a chronic inflammatory component, which, definitely is something that diet should and could be used to actually help to combat, not as the single cure, but really as something that needs to be paid attention to. And there are efforts now looking at that. And then neuropathy, there's problems with nerves that actually develop that we don't understand, whether it's the brain, spinal cord, peripheral nerves, cranial nerves, the nerves in our head, in our face. Those we don't really fully understand. So therefore, most of the people who are not feeling well after recovering from COVID, what I would recommend, go to your doctor, and if your doctor doesn't really know what to do, look for a post-COVID or long COVID clinic. There are lots of these clinics. Most of the major hospitals are beginning to create them. I wouldn't tell you they know exactly what to do yet, because they're just starting to collect the data and trying to formulate the hypotheses to understand how they could be helped. But, perhaps, Dr. Montgomery or Dr. Esselstyn, you have some experience with these long COVID patients that might be beneficial.
Yeah, thanks. I'd like to have a few comments, and thanks for your insightful thing. One, I'm going to throw some comments and questions, so make some notes, because this is a very pregnant topic. First and foremost, the concept of vitamin D. I think there's some data showing very strong correlation with very low vitamin D levels and mortality. Dr. Lee, you mentioned very insightfully that the survival rate of this disease, by and large, is better than 99%. Regarding the vaccine, and again, I'm not going to say I looked at every data on the vaccine. I looked at Moderna's data and I looked at Pfizer's data. And what I gleaned from that data is that they showed efficacy in preventing mild infection of coronavirus. This is a relatively young, healthy population. Median age in Pfizer's was 52. And there was no significant deaths in the control or treatment groups in either of those studies. So that means there was no survival benefit. That's number one. Number two, the elderly population was not well represented. Number three, people with comorbidities were not well represented. Pregnant women were not well represented. In Pfizer, they excluded patients who had already had COVID. I don't think they did in Moderna. I had one patient who had COVID, was in Moderna. And I did not get a chance to look at J&J's data, although they touted a 66% efficacy compared to the other two, is about a 95% efficacy. But the efficacy in these vaccines, based on the published data in the New England Journal, was efficacy in reducing mild infection by and large, not survival benefit. So if you have a disease state which is 99% survived with nothing, but the immune system, and we can all tout in our discussions, our population is a very sick population, so we don't have the healthiest immune systems to start with. So in a population of people with an unhealthy immune system and a 99% survival rate, just imagine what can you do if you give them more plant foods. As diligent as I am about 100% raw fruits and vegetables, if I say just increase the amount of plant foods, I think we can boost that survival rate even more. So in my practice, I see a number of patients who come in asking about the vaccine, and I only advise my patients based on their clinical conditions. So I'm not advising the audience. So I'm going to say to the audience, do what your doctor says is best to do. So I'm going to preface my statement with that. But certainly in my practice, I don't lead with recommending the vaccine. Personally, I haven't gotten it. But the reason is not so much based on any theories or crazy things on the internet. Is based on Pfizer's data and based on Moderna's data published in the New England Journal. And what Pfizer says about their vaccine, what Moderna says about their vaccine, is that it does not improve survival. That's the message from Pfizer, message from Moderna, based on their publication. So based on that, and I have someone who has a disease state that's 99% survival, when we have other therapeutic interventions such as a plant-based diet, which boosts the immune system. We can all agree that a healthy immune system, with or without a vaccine, if you have a very poor immune system, I don't care what kind of vaccine you have, a vaccine relies on stimulating an immune system that has to have some capability of fighting a bacteria, virus, or whatever you're trying to immunate the person from. So you have to have a healthy immune system to start with. That's number one. Number two, we can do other things to stimulate. Ivermectin is a drug that no one talks about a lot, but there's a lot of published data. And I'd like to get your input on this across the different countries. Now, there's no large randomized multi-trial data. That's the criticism it gets. But there are small randomized studies, about 38 that I've counted, that's shown survival benefit of 93%. Ivermectin, as you know, is a drug that's been on the market for over 40 years. There's nearly 4 billion prescriptions given and only roughly 16 reported associated deaths, which we're not quite sure of. And it was on the World Health Organization's one of the most important drugs around, a very low side effect profile. And I've used it prophylactically in my patient population, also therapeutically. And we've seen great data. There are many critical care physicians who've seen great data around the country with this drug. So the safety profile is much greater. There is some survival benefit compared to the vaccine, which I'm not aware of it having survival benefit. It has reduction in infection benefit that I've seen in the published data, but not survival benefit that I've seen. And so that's why I lean more toward natural approaches. First and foremost, ivermectin, hydroxychloroquine has also benefits as well. Ivermectin head-to-head with hydroxychloroquine, ivermectin was proven to be better. But I think there are many tools we have, and I have treated some patients with this long COVID syndrome. Long COVID syndrome is reminiscent to me of a post-infectious sequelae. I had a number of patients in my practice over the years who will give me a history of a viral infection. One patient comes to mind off the hand. He was sitting in a movie theater and he was next to someone who had a cold or flu and they were sneezing. And a few days later, he was sneezing and he had a viral infection. Long and short is this. Shortly after that, he had this severe neurological problem where he came into my office and he can hardly walk, had nearly paralysis in his lower extremities. We did a number of tests. And based on that history, I hypothesized, look, you have some kind of a post-infectious sequelae. It was an autoimmune disease that affected his nerve system. We have textbook cases of this, strep throat, for instance, again, a post-infectious sequelae, when you have autoimmune effects on the heart, autoimmune effects on the kidney, autoimmune effects on the genital. So these disease mechanisms, they don't always come with titles and great textbook cases, but they present themselves in very vicarious ways. So post-infectious sequelae in the setting of this patient with another virus, I think we're seeing a similar thing with COVID and the long COVID syndrome, where patients have an exacerbation of, say, an underlying chronic illness, or they can have a neurological complication. They can
Please
have a
welcome to the
cardiomyopathy of the life.
2021.
So you have a situation with a post-infection where the immune system is tripped up, and there's an autoimmunity. You could have an infectious autoimmunity, a pathogenic autoimmunity caused by a primary infection. Some people talk about pathogenic autoimmunities caused by vaccines, but it's a very similar mechanism that we're seeing with these long-term effects. So what I try to do is I try to do things that go against the autoimmune process, because as we all talked about, these similar mechanisms, inflammation, autoimmunity, triggering different types of cytokine reaction, they can happen with an infection, they can happen with a pseudo-infection called a vaccine. So what we need to do is go to the natural state of immunity with natural food, natural detoxification, also less, more benign drugs to treat an acute infection. Ivermectin is only used for about 7 to 10 days. People get better in just a couple of days. All of my patients are getting prophylaxed with ivermectin plus quercetin and zinc, vitamin C, vitamin D, all of these things up front to help boost the immune system in addition to a plant-based diet.